afternoon. My name is Amy Morgan, and I'm a neuropsychologist with the Mass General Hospital and the Myhre Syndrome Clinic. I'll be talking about learning and behavior in Myhre syndrome. The information I'm presenting is from review of the literature and based on what I've learned from working with you, my patients. So as an overview, I'll be reviewing the general learning profiles of individuals with Myhre syndrome, and then with a focus on autism and behavior, speech and language skills. I'll review concerns about motor development and hearing difficulties and how each of these can relate to an individual's learning and behavior. Finally, I'll talk about interventions and what I generally recommend for my patients. So first, I'm going to review the general profile and concerns relevant to Myhre, and then talk more in detail about cognitive, language, autism, and behavioral issues. In general, typical profiles in individuals with Myhre syndrome, although not all individuals, include developmental delays, which are evident in most, speech difficulties due to articulation deficits, and then language processing weaknesses. There's also a high incidence of autism and sometimes behavior difficulties, which I believe are more related to autism learning, sensory, and perhaps motor limitations than to a behavior disorder or difficulty on its own. An additional concern may be hearing difficulties or hard of hearing that may progress to more complete hearing loss over time. Now, with regard to motor skills, there is likely to be motor skills in individuals with Myhre due to the nature of the genetic disorder affecting bones and joints. Associated with this can be motor planning, which is defined as the ability to organize the body's actions, that is, know what steps to take, in what order, to complete a particular task. For example, a motor plan for getting dressed would include steps for putting on socks, knowing this comes before stepping into shoes, putting shoes on the correct feet, and so on. Children with motor coordination and planning difficulties also often avoid new experiences because they know it will be hard for them to keep up or appear typical, so to speak. They often respond with, I don't know, or I don't want to, and sometimes might appear aggressive in hitting or pushing if they become anxious ahead of the new activity or social situation. So motor skills can understandably directly contribute to difficulties with cognitive development, the activities of daily living, communication, and social development. Cognitive and learning difficulties also vary, with the test scores ranging from average to well below average, even within one individual. Even when some skills are within the average range, there is often considerable variability among all the scores. And in fact, this is evident in many individuals with or without a medical or genetic condition. But typically in Myhre, we see scores higher on verbal tasks and people having greater difficulty on nonverbal tests that place demands on fluid or flexible reasoning and problem solving. As I mentioned, test scores can range from average to well below average. In the 12 patients I've seen thus far for neuropsychological testing at Mass General, half have scores in the range of a mild intellectual disability, and some of those have scores in the average range as well, but overall mild intellectual disability, and half have scores that range from a moderate to a severe intellectual disability. Now, for individuals with a mild intellectual disability, there can be well-developed self-care and some home care skills, communication skills, etc. But he or she will likely need help with more complex or multi-step tasks, such as coordinating medical care, legal and money management, home upkeep, and so on. Academic skills can be acquired up to an approximate 6th grade level, but that varies amongst, from child to child. Individuals with a moderate to severe intellectual disability will need support and supervision for their activities, but will continue to learn with long-term instruction. and intensive repeated instruction, and when the information or instruction occurs in a meaningful context, such as learning the skill in the setting in which the skill is to be used, at home, household activities, self-care, etc. Speech is often limited, meaning that articulation or the speech muscle's ability to form sounds, syllables, and words is adversely affected. Language can be a strength on testing, although it can be most strong at the single word level, with individuals showing good use and understanding of single words, two-word combination, or brief phrases. The difficulties with language processing typically are most evident in the use and understanding of grammar, that is, use of pronouns, verbs, adjectives, etc., and syntax, meaning organizing the way words are arranged in sentences to form different meanings. And then word retrieval is also often quite difficult, meaning that the individual will know what he or she wants to say, but have great difficulty retrieving or getting the word out. Now, I think we all have that difficulty once in a while, but to have it most of the time can be particularly frustrating, could make the person withdraw or not want to engage with others, or engage awkwardly with others. People with word retrieval difficulties can often talk about a lot and easily about topics of their own choosing, but when they're asked questions, or even when required to engage in conversation, the back and forth of conversation with others, this is when you see them having the real word finding or retrieval difficulty. So now we come to behavior and Myhre syndrome. And autism is common in this population. So I first want to briefly review what autism is, although most of you probably already are familiar. But for a diagnosis, the individual has to exhibit two things. First is significant limitations in social communication and interaction. And this could mean limited eye contact, difficulty understanding others' interests or emotions, taking others' perspective on things, or difficulty initiating or responding in the back and forth of social interactions. And then number two is restricted or repetitive behaviors. So this might range from anything such as hand flapping, the need for the same routine or keeping objects in the same order, the inflexible behaviors, and then related to that inflexibility is great difficulty managing transitions or changes in routine, particularly if they're unexpected and the person isn't given a heads up about the upcoming change. So the next few things are not necessary for the diagnosis, but often seen in individuals with autism. And this is an undersensitivity or oversensitivity to sensory input, and or unusual interest in the touch, smell, feel of objects, and sometimes being drawn to lights, especially colored lights or flashing lights. So undersensitivity is often seen as seeming to not feel pain or having a very high pain threshold. And oversensitivity, as I think I'd mentioned, is just the being overly sensitive to touch, sound, or smell, things like that. In the literature to date, the incidence of autism in individuals with Myhre ranges from 50% of the patients seen to over 85%. Now, in the population that I've evaluated thus far, the incidence comes to around 2/3, or actually to exactly 2/3 in children. Now, the patients not diagnosed with autism most often show mild social and behavioral vulnerabilities, although they don't meet criteria for autism. So these mild vulnerabilities are typically seen in some inflexible behaviors, liking things in a particular order, and having mild difficulty taking others' perspective, for example, although these difficulties do not rise to the level that causes significant difficulty in day-to-day life. In my opinion, it's still critically important to provide help and intervention for these children, just as you would for a child with autism, so that these relatively mild difficulties do not cause increasing problems for the child or the adult over time. Now, behavioral difficulties most often reported in individuals with Myhre include hyperactivity or being overly active, inflexibility, low frustration tolerance or being easily frustrated, limited communication skills, sometimes due to articulation, sometimes due to language deficits, and sometimes aggression. I view these difficulties in the context of general limitations in other skills, such as motor, learning, social communication skills that have not yet been appropriately addressed. And so the child is acting out in frustration. Now, because I believe appropriately addressing autism is so important in any population, I've included this list of behaviors. It's not inclusive of all behaviors that are evident in children or adults with autism, but I think it's important to know a little bit more about the behaviors often seen in people with autism, and you can review it at your leisure. So now that there may be a better understanding of a child or adult's a profile who has Myhre syndrome, what do we do about it? So first of all, for adults, and I work with children, but I know there's many adults with Myhre syndrome, you'll have to be an advocate for yourself or find someone who can help others understand the many issues you're dealing with, why you're having the difficulties you're having, and how others can help. And I found that often just having others better understand you can be a powerful support for you. You're dealing with issues that others can't even imagine and would be very unlikely to be able to manage on their own. Some of the interventions and supports I'm going to be recommending for younger children can also be helpful for you. And so don't stop listening just yet, because the next may be helpful for you as well. Now, for parents of younger children, it's important for you to be their advocate or one of their advocates, as you will often do the best job of explaining why your children is having the difficulties he or she is having, and why specific services are necessary beyond the fact that my child has Myhre and speech difficulties, perhaps autism, etc., but how all of these things tie together and why the services are therefore so critical to your child's success. So for younger children, I always recommend that the diagnoses and supports begin as soon as possible. The brain is most plastic or able to form new connections at younger ages. But also for adults, development continues to occur throughout life, thankfully, and our brains continue to learn and gain new skills throughout our entire life. But if there are even mild concerns about autism, consider getting an evaluation as soon as possible, obtaining an appropriate diagnosis, and then getting appropriate services. One of the reasons the evaluation is so important is for the diagnosis, but also for the type of instructional services that children diagnosed with autism have a better opportunity of receiving than children not being diagnosed with autism. So now for the services, prior to the age of 3 through early intervention, and then at age 3 and up through the public schools, or in some cases private schools, I recommend that instruction be in the form of ABA, Applied Behavioral Analysis, which I will explain at the end of this talk, or ABA type services, which I'll go over in more detail, as I mentioned. Speech language therapy is also critical. Now, for some children who are nonverbal or for whom articulation is particularly limited, which we often see in Myhre, an augmentative communication evaluation and then use of a device such as an iPad or other kind of computer type of device with appropriate software can be used to help the child communicate more effectively as part of the speech language service. And then depending on the child's needs and this type of setting that they're in, I often recommend that speech language instruction take place daily. Now, a lot of that service can be provided within the classroom and not necessarily with the speech language therapist directly, but that perhaps a classroom aide can incorporate instruction into class throughout the day, emphasizing the particular aspects of speech and language development the therapist would deem the most appropriate or important at that time. And then the therapist, of course, would perform 1 to 2 sessions a week as well. With regard to occupational therapy, I often recommend a similar in-class service, particularly if there's substantial sensory processing and motor planning difficulties that adversely affect the child's ability to learn or to engage with others. Again, the OT does not have to provide direct service each day in the class, but should oversee an aide who can do so. So as I had kind of mentioned earlier, the instruction is in the context of the child's day instead of always a pull-out therapy and then having to incorporate what he or she has learned in the classroom. Physical therapy at least once a week is recommended. And I would also emphasize to the school the need for physical activity throughout the day and movement throughout the day, as well as adapted physical education that is adapted in a meaningful and helpful way for the child. Social skills instruction may be in the form of a developmental play group for young children, or maybe in the form of a social skills group of some sort for children over the age of 3, perhaps run by or overseen by a speech language pathologist. The group instruction might take place 1 to 2 times a week, but for children of school age, 3 and over, I would recommend in-class supports all day to be provided for the child. They can be informal with the aide. And I would also recommend that other students in the class have help understanding what your child with Myhre syndrome is dealing with, how they best respond to information, et cetera, which is really kind of a gift to the whole class as well. Now, for children who are deaf or hard of hearing, it will also be critical for any education program to offer specialized instruction throughout the day. The accommodations should include personal technology or hearing devices, assistive technology such as a text phone, for example, instructional modifications, noise reduction in the classroom, and other learning settings, noise reduction, just to name a few things. I would strongly recommend pulling in experts in the deaf and hard of hearing to support and to come up with the education plan. I'm also, for children with Myhre syndrome and other similar rare developmental disorders, a big fan of music therapy or the use of music for instruction. Music has been shown through research to facilitate the use of, or the development of communication, learning, and daily living skills. The predictability of music can also improve cognitive, communication, and social functioning. So just as an example, a song could target certain letters to try to improve articulation or help a child use words, more elaborated language appropriately, using appropriate grammar and syntax. Music can be used to help children remember information such as phone numbers, addresses. It can be used to target a specific skill such as brushing one's teeth, or perhaps for motor skills such as walking, jumping, and for social skills such as making eye contact, taking turns to play instruments or other social interaction games. So now, applied behavioral analysis is a specific and specialized approach to learning, to improve learning and behavior, which is based on how the brain actually learns and how behavior develops. ABA is used to increase behaviors that are useful and decrease the occurrence of behaviors that adversely affect learning and developmental progress through using repetition and positive reinforcement. ABA basically just means that novel tasks and the targeted behaviors that we want to help the child improve are broken into small, achievable steps with rewards provided when the child completes each step. The reward can be just the feel-good feeling of completing something successfully, or it might be something as food, a preferred game, pat on the back, etc. So then the ABA approach provides students with a strong foundation on which to build increasingly complex skills. The goals or targeted skills can include communication, social skills, flexible thinking, sustained attention, and even acquisition of academic skills and higher order executive functioning like planning and problem solving. Not every form or all instruction with ABA needs to be with someone who is certified in ABA, which would be a board certified behavior analyst, BCBA. And this is why I sometimes put in my reports that ABA type instruction can be used so that it's using the principles of ABA, especially if the child does not have autism and may not have as easy access to ABA instruction, but that they're still getting the benefits of ABA instruction, ABA type instruction. So in conclusion, children and adults with Myhre face many challenges, each of which can be seen as having an impact on the child's learning and behavior, the motor challenge, the motor difficulties, etc. It's a rare disease, and there is not yet a lot of data available on affected individuals' cognitive, behavioral, and learning profiles. While we gather the additional information, it's important to use what we know thus far, and also what's been learned from the experiences with other rare disorders as we gradually increase our understanding of Myhre, educate others, and advocate strongly for the most important interventions. Thank you so much.